So hi guys and welcome to this Catalyst classes. So in these classes we are going to discuss about one of the most important topics such as ECG. If you take this Norcet exam and it is conducted now yearly twice, and each of the shift you can find minimum one question. So like if you take since from 5 to 6 consecutive years, you can find like 15 questions from ECG from this single topic itself. So I will be discussing about each and every aspect and how to read the ECG and what are all the causes and their treatment aspects also over here. So let's begin our discussion of today's topic is ECG. So if you take an ECG, let me teach you some basic concepts in the ECG. So if you take the ECG strip over here, and here if you look like this is a large square. Okay, let me zoom it. This is the large square, and inside the large square there are some small squares. How many small squares are there? 1, 2, 3, 4 and 5. Okay, so let me teach you, like, don't remember in decimals and all, like 0.04 seconds and all. So we will go in like numericals. It's of 10, 20, 30, 40 only, because like 0.04 and all, it will be a bit confusing for you. So let me teach you, like what I taught you now is, this is a large square. Inside this large square there are 5 small squares. 1, 2, 3, 4 and 5, right? The duration of one small square is 40 milliseconds. Okay, so if you convert into the second, 0.04 and all will be coming, so like that will be a bit confusing. So remember, the duration of one small square is 40 milliseconds. So for 5 it is like 40 into 5, it's like 200 milliseconds. No, so one large square, how much it will contain? Like it will take like 200 milliseconds. Okay, this is some basic which I am going to describe in front of you. So let's start our duration. Like, so what happens, like let's begin our discussion over here. So if you take the ECG, we all know P wave, Q wave and RS, QRS complex and T wave. So let's discuss how they will get generated. Suppose look at this. So let me hand draw normal ECG for you. This is P wave, Q, R, S and T wave. Q, R, S and T. This is the normal ECG. So let me discuss about now P wave, right? So how this P wave will get generated in this. So P wave, how it is generated in the sense is like, suppose imagine this is the heart and this is right atrium and this is left atrium. P wave, how it is generated is nothing but, P wave is nothing but the current, the firing system of an heart is SA node. No, SA node is nothing but firing system of an heart. So whenever the SA node will fire a current, SA node is present over here. When it fire a current, it is sending the current to the left atrium to right atrium, right atrium to left atrium, right atrium to left atrium. So that current is going. So what actually happens in P wave, how P wave is generated in the ECG is, if you take this SA node will send some current to left atrium and right atrium and left atrium, so that atrials will get depolarization. So that's why P wave, what it indicates? Atrial depolarization. Okay, this is the reason how P wave is generated. P wave is how it is generated. Current is firing from the SA node, so it is transmitting from right atrium to left atrium. Okay, this is the reason why P wave is generated. So we should know two important points about the P waves. So if you look at the amplitude is nothing but height. Normally P wave height is less than 2.5 mm. So I will teach the abnormalities also, like P mitral and P pulmonale, in upcoming slides. So for time being, remember the normal values. This is normal amplitude. right? So amplitude is nothing but this one, height. Okay, so this is your amplitude. And if they ask you the duration, so duration is nothing but this breadth of an p wave is nothing but the duration. So if you take this duration of p wave is nothing but breadth. So breadth is how much? Less than 120 milliseconds. So less than 120 milliseconds is nothing but, if you come in fit into the how many small square boxes, I thought you like each small square is 40 and multiply with 3, so 120 is nothing but 3, no, so that's why it fills in that less than 3 small squares. So why you should know about these small squares and boxes, are like we'll be studying like narrow QRS, broad QRS and also, that's why this is very important. So this is about P wave abnormalities. So now let's go on to the PR interval. So what do you mean by this PR interval is, this is P wave. So let me draw you normal ECG, Q, R, S and T, right? So remember PR interval is nothing but here starting of an P to starting of Q wave. This one, this whole is like PR interval. So let me zoom in for you. So let me write clearly the diagram. P wave, Q, R, S and T. So I am teaching PR interval. This is starting of an P wave to this one, starting of an Q wave. This is about PR interval. Okay, so this, don't confuse like starting or ending, right? So I will write it clearly for you. PR interval is nothing but starting of P wave to start. Remember PR is coming first, so that's why start and start. Starting of an P wave to starting of an Q wave. Q wave. This is about PR interval, right? So how this PR interval is generated is, look at the over here. I taught you current will go from SA node to, in last P wave current is generating between right atrium and left atrium. So if you come to this condition, the current is moving from SA node to AV node. No. So generally the current will firing system SA node to AV node to bundle of his, bundle of an is to Purkinje fibers, then rest of the heart row. So this is the same sequence. Now when the current is flowing from SA node to AV node, there is a delay in the current, right? Delay in the passage, right? So how much? 0.1 second. There is a delay. So why it is delay here? Vagus nerve is coming into the action. So vagus nerve, what it will do, like it will delay the passage of the current to the AV node by 0.1 seconds. So this is also known as, so that's why AV node, it is also known as gatekeeper of an heart. So why it is gatekeeper? It is delaying the conduction system of an heart by through 0.1 seconds. Okay. So now this is about, so how this PR interval is generated? By through the delay of AV nodal conduction. Whenever current is passing from SA node to AV node, there will be a generation of an wave interval known as PR interval. That's it. Conduction. So now let's discuss some normal PR interval. So PR interval is nothing but, which I have marked in this. So normally the PR interval is nothing but 120 to 200 milliseconds. So from through small squares, if they ask 3 to 5 small squares. Okay. So why this value is important? Normal PR is 120 to 200, because we'll be reading the conditions like a short PR interval, prolonged PR interval and all, right? So that's why this reason is important. And next is like Q wave. So how this Q wave will get generated? Like most of the students, they'll be answering like Q wave is generated due to ventricular depolarization. No, Q wave is generated mainly due to septal activation. So how? SA node to AV node to bundle of an his to next it will go to Purkinje fibers. Na? This is the normal conductance system. So Q wave is nothing but here septal activation is coming over here. The current is spreading between the interventricular septum, right? So this is the reason why Q wave will get generated over here. So normal duration of Q wave is Q wave will fit in each small chota square, no? So Q wave will fit in this small square, one small square, this Q wave. So that's why the duration of an Q wave is 40 milliseconds. Okay, so this is the reason why Q wave will fit in small square. So in some conditions like MI and all, we will see this capital Q. So what do you mean by this capital Q is the Q wave will not fit in this small square. It will fit, the Q wave will come outer than the small square, right? So that is like capital Q. So what does it indicates? Cell death. Cell death in MI. Okay. So this is about Q wave. And next we have it when we come to this QRS. So what do QRS it will what it indicates? QRS it indicates ventricular depolarization. So now after knowing the function, so what how in how many squares it will fit is the duration of QRS is 80 to 100 milliseconds. Okay, 80 is nothing but 2, 100 is nothing but 2.5 small squares. Okay, and next let's discuss some about QT. QT is very important. So we all know QT is inversely proportional to calcium and all. So what do you mean by this? QT is starting of an Q wave until end to T. Okay, so let me hand draw for you. P wave, Q, R, S and T. Okay, Q, R, S and T. So what this QT interval, what it indicates? QRS complex and this T. Okay, so what this QRS is nothing but, so QRS is nothing but we all know QRS is what QRS will indicate? Ventricular depolarization. So what this T wave it indicates? Ventricular repolarization. Okay, so QT is the combination of ventricular depolarization and ventricular repolarization. So what is the duration of the QRS? We all know like QT interval is like 360 to 440 milliseconds. So if you come to this squares fitting, it will fit into 9 to 11 small squares. Okay, and this is about QT interval. So we all know QT interval is very important, and go through this once, like from where it will start, starting of an Q wave to end of an T. Starting of an Q wave to end of an T. This. Okay, this is about your QT interval. So we all know QT interval is inversely proportional to calcium. Okay, and one more point over here is PR interval is inversely proportional to your heart rate. Okay, the heart rate increases, PR interval will decrease. This is the relationship. And this is about QT segment. And next we move to the T wave. So what does this T wave it indicates? T wave it indicates ventricular repolarization. Right? So if you come to this T wave is measured in terms of an height. Okay. So normally T wave height is less than 5 mm in your limb leads and less than 10 mm in your chest leads. Okay, so this is about the T wave. So these are all about P wave, PR interval, Q, QRS, ST segment and everything like QT and all, and T segment and all, right? So these are all about PQR ST waves, and I taught you like how they are generated and all. Okay, and now let's move to one of the ECG. So how do you calculate the ECG is nothing but it's a very simple like heart rate. How do you calculate heart rate in the ECG is like This is an R wave and this is an R wave. And look at the how many large squares are present. 1, 2, 3, 4, right? So how do you calculate heart rate? Look at the RR interval. So how many boxes are present in the RR interval and all, right? 1, 2, 3, 4 large squares. No, then divide it by that much. Heart rate is equals to 300 divided by RR number of large squares that are present in RR interval. So now in the given ECG is nothing but 300 divided by 4. 1, 2, 3, 4. This is an R wave, this is an R wave. In between that, how many large squares are present? Then divide it by that. So that you will get an heart rate over here. So that is 75 per minute. Okay. So this is about how do you calculate the heart rate. So whenever if you read this condition like heart rate calculation, so whenever ECG is present in front of you, go through the heart rate calculation. Whether so by like calculating the heart rate, you will get to know whether it is a tachy or bradyarrhythmias, right? And next is like very simple, and this is the very important box. If it is greater than 5, like 300 divided by 5, and if it is greater than 5, number is greater than 5, 4, 3 and all 5, right? So that leads to your 5, 6, 7. So that leads to your bradyarrhythmias. If it is less than 3, no. So remember like what do you mean by this less than 3 is, so like 300 divided by 3, it is 100, no? And 300 divided by 2, 2 ones are 2 and 2 fives are 10. So this is 150. And 300 divided by 1 is equals to 300. So this is about this, right? So if the number will keep on decreasing, and that will become tachycardia. If it is greater than 5, no, like 300 divided by 6, so if you go with this, and it will be like less than 60 and all, right? So these are all about bradyarrhythmias. So how to calculate the heart rate? If your large squares are coming more than 5, that is your bradyarrhythmias, and if your large squares are coming less than 3, that is your tachyarrhythmia. This is the how you can calculate the heart rate in a given ECG. And next we move to some of the P wave abnormalities. So I thought like P wave abnormality is very important. So there are two P wave abnormalities. One is P pulmonale and P mitral. Okay. So what do you mean by this P pulmonale and P mitral is? So look at the height of this P wave. I thought you like height of the P wave normally it is less than 2.5. Less than 2.5 in the sense like it will fit in like 2 to 2.5 small squares, but in this condition if you look at this P wave height, it is more than 2.5. okay, so if the P wave height it is more than 2.5 mm, so that is called as P pulmonale. Okay, look at this like height of this P wave, this one, so it is more, right? So that condition is known as, if the height normally I taught you it is less than 2.5, but in one condition you will find that height is more than 2.5, that is known as P pulmonale. So why it will occur this P pulmonale is like mainly due to this, whenever your right atrium will get enlarged, you will find this height is more than 2.5. This is the reason where you will find this right atrial enlargement and P pulmonale. Best example in terms of your COPD patient and your pulmonary artery hypertension, right? You will find this P pulmonale. And next one more P wave abnormality is P mitral. No, so P mitral and P, this is like I taught you normal breadth of an P mitral. This one I thought you normally it is less than 120 milliseconds. Okay, in the sense 120 milliseconds in the nothing but it will fits in 3 small square. But look at over this ECG, it is like 1, 2, 3, 4, 5. It is going more than 3, 5, right? So that's why it is like breadth is more. And if you look at this wave, how it is looking like M shape, this is P mitral. And what is the abnormality over in P mitral is the duration of P wave, like the breadth of an P wave, it is greater than 120 milliseconds. Okay, this is about p mitral. So where do you will see this? It is seen in, yes, left atrial enlargement. So left atrial enlargement, so where you will see in mitral stenosis. Okay, so this is about two P wave abnormalities. So we'll be going like sequence order. So P mitral and P pulmonale. So where you will find P pulmonale in right atrial enlargement in COPD and all, and P mitral. So now you know pulmonale is nothing but something which is height is more than 2.5. P mitral is nothing but duration or breath is greater than 120 milliseconds. Okay, so this is about P wave abnormalities, and I will teach you one more important line. This is very important. Absent P wave is seen in atrial fibrillation, and one more condition, that is your sick sinus syndrome. And in electrolytic imbalance also we will find hyperkalemia. So I will be discussing like ECG changes in hyperkalemia and hypokalemia separately. So like in absent P, so whenever in cardio session, if you look at this condition like absent P wave, if the examiner he mentions that absent P wave, you should think about two conditions, that is your atrial fibrillation and SNS, sick sinus syndrome. Okay, so I will teach you how to differentiate between atrial fibrillation and sick sinus syndrome. So next is like Wolf Parkinson White syndrome. So what do you mean by this WPW is, normally in you and me, the current will always flow from single direction. AV node, it will follow this pathway. AV node, SA node and AV node, and next bundle of his, and next is Purkinje fibers. Right? So this is about normal conduction system in an heart. But now I will teach you one condition. Now I will teach you one condition. The current will flow from, this is normal condition which I have drawn, but this is an abnormal which I am going to teach you. Purkinje fibers, right? So here what will be happen? No, the current will flow directly to this pun. Purkinje fibers or bundle of NHs, right? It is going to skip this condition, this pathway. This pathway is going to skip in this condition. So that is like it is bypassing. No, like the current is not going from SN node to AV node to bundle of NHs and all. It is like it is directly it is going to bundle of NHs Purkinje fibers over here. So that leads to the fast conduction, right? So why? Whenever this AV node current will pass through the AV node, I told you like AV node it will put an break over here, so that's why there will be a delay here in this condition. In this WPW, Wolf Parkinson White syndrome, the current is not at all going over here, right? Bundle of His and Purkinje fibers and all over here. So that's why it is directly coming to the Purkinje fibers. That's why the heart rate of this patient is very more. It is not giving the time to ventricles to relax itself. Okay, so that's why heart rate is more in this patient. Heart rate is more, right? So this is known as bundle of Kent. Bundle of Kent. So what do you mean by this bundle of Kent? Where you will find in WPW, Wolf Parkinson White syndrome. The current is flowing directly from SA node to Purkinje fibers or bundle of NHs. It is skipping this AV node. So this is like fastest conducting, no? So ventricles are keep on contracting, and they are not at all relaxing in this condition. So this is the reason why like heart rate is more over here. So like this is about very important. So what are all the ECG findings? I will show you. I will hand draw the ECG for you. Like, so that's why you find there is a short PR interval. So I will hand draw the ECG. How does it look over here? Like here Q wave is not coming. Q wave is, why it is not coming? Absent Q wave is found in WPW, Wolf Parkinson White syndrome. Why it is absent is like current is not at all flowing to like AV node to bundle of an his, no, and it is directly going to the Purkinje fibers and all. So that's why I thought you Q wave where it will get generated in the septal activation, right? When the current will force from interventricular septum, then Q wave will get generated. Here current is not at all going to the these Q wave, like bundle of NH. So how there is like abnormal current? No, it is going, it is skipping the pathway. So that's why there is an absent Q wave in this condition. So that's why if you look at the ECG, like if you look at the ECG, there will be this one upstroke, right? So upstroke is nothing but this is an anything in the ECG which is going up is R wave and which is coming down is S wave, right? So if you look at the ECG of this patient, it will be like this. No, this upstroke, this is known as your delta wave. So this is your delta wave. Delta wave is the characteristic feature of WPW. Look at over here. How does it is looking? So look at the wave over here. So this only I have hand drawn over here. So PR interval is also short, and this upstroke, which the red arrow is over here. This upstroke over here, this is a delta wave. So this is an abnormal wave. So this is about the WPW, Wolff-Parkinson-White syndrome. Okay, and next we move to PR interval abnormalities. So what actually happened? Let's study over here. So when I thought duration of an PR interval 120 to 200 milliseconds. So if you look into this PR interval, we have two types, that is short PR interval and one more is prolonged PR interval. Okay, so we all know short PR wave you're gonna see in tachycardia, and I thought you just know itself short PR WPW, and prolonged PR where you are going to see is like in rheumatic fever. So I thought you how this PR interval is formed, like current is passing from SA node to AV node, no? So that is the reason why this PR interval is formed. If there is delay in the passage of current from SA node to AV node, so that leads to the prolonged PR. So for that, one of the reason is rheumatic fever. So we all know in my cardiology session also I have discussed about like rheumatic fever and all. From SA node to AV node, current is flowing, but in this disease condition, what it will be happen is like there will be formation of these Ashkoff nodules. So due to this, there is a delay in the passage of current, right? Delay in the passage of current. So that leads to prolonged PR. Okay. And next, one more condition I want to explain is first degree heart block. Okay, so what do you mean by this first degree heart block is like, so everywhere the PR interval is more. So if they ask how much, what is the criteria to tell like first degree heart block is like your PR interval should be more than 200 milliseconds. Okay, so like what actually happens is this is like it is found in like marathon runners, no, marathon runners, right, where there will be like moving there very fast, so like they will be walking or they will be running very fast. In such kind find this, we will be finding this first degree heart block. Okay, and next we'll move to the one more condition, that is like Mobitz 1 heart block, Mobitz 2 heart block. So I will be discussing about PR interval. So if you look into this, like Mobitz 1 heart block, Mobitz 1 heart block, no? So why this Mobitz 1 heart block occur is like, so if the person is taking this beta blockers, right, for hypertension, and if he be using like unequal doses or like dosage problem, or he will be keep on excess using of this beta blockers and all, like, so that leads to the Mobitz 1 heart block or like Mobitz 1 heart block. So this is like if you look at the PR interval of this patient is like it is get prolonged in this condition wherein Mobitz 1 heart block. So one more condition where PR interval is normal. So most of the students, they will be answering that PR interval is like abnormal in Mobitz 2. No, PR interval is normal. I will be teaching in Mobitz 1 heart block. PR interval is not same. One PR interval it is big and one PR interval it is small. I will be teaching in subsequent ECGs also. So these are all about where you will find this PR interval. So next, firing system or firing rate is nothing but very simple. So you should know that SA node, how much it will fire, how much it will generate, the heart rate is 60 to 100 per minute. Then about AV node, how much it will generate? Yes, AV node it will generate 45 to 60 per minute. Okay. And next, when we come to bundle of His, so how much current it can generate? Less than 40 per minute. And next is Purkinje fibers. So how much they can generate? 15 to 20 beats per minute. Okay. So these are all about firing systems of an heart, how much it can generate. Suppose imagine if SA node won't function in the person. I will be teaching the conditions in upcoming slide also. These are all basics. If SA node is not functioning, God has created one more thing, that is AV node. If AV node is also not functioning, then it is bundle of His. If bundle of His is also not functioning, then Purkinje fibers will come into the action. So this is the reason, like how God has situated, like in some condition SA node won't fire, then AV node will come into the action. Whenever AV node will come into the action, your heart rate can be max. The heart rate can go max up till 60. That's it. Whenever bundle of His come into the action, your heart rate cannot cross 40, and max to max it can, its capacity itself is the 40, it cannot cross the 40. Okay. So this is about firing systems. And next we move to one of the most like bradyarrhythmias. So now we will be going to the main ECG concepts, six sinus syndrome. So what will happen over here is, like I thought you know. So bradyarrhythmia is nothing but, look at the heart rate over here, 1 2 3 4 5 6 7 8 9 10, like 300 divided by 10, like it will be like very less over here in this condition. So one of the best hallmark feature of absent P wave. So remember, absent P wave is seen in two conditions. One is bradyarrhythmia and one is tachyarrhythmias. In bradyarrhythmias, like in where you will find this six sinus syndrome, absent P wave is present over here, right? But in tachyarrhythmia, like atrial fibrillation, also absent P wave. There irregular pulse is found in atrial fibrillation. But when you come to over here, there is like pulse is present over here. So like absent P wave, but heart rate, if you look at your ECG, if I draw for you, P wave is coming, QRS, and over here, and here there is absent P wave. No? And heart rate will be less than 60. Okay, P wave is coming, and like in some case it will be absent. So look at here, P wave is absent over here. So this is the ECG over here. So like if you look at the heart rate in this patient, heart rate will be like always less than 60 per minute. Look at over here, ECG, absent P wave. No? So this is the characteristic feature of this. And next is like bradyarrhythmia with absent P wave is six sinus syndrome. I am repeating, tachyarrhythmia with absent P wave is atrial fibrillation. Okay. And whenever this like a six sinus syndrome, when it will come, whenever there is malfunction of SA node. Whenever SA node won't fire, I taught you know who will come into the action? AV node. So that's why heart rate is always here. I wrote less than 60 because SA node is not functioning properly. AV node is the heartbeat generation over here. And next, when your AV node won't function properly, AV node malfunction, that leads to, yes, that leads to complete heart block. Okay, so I will teach you what you mean by this complete heart block is, SA node is functioning, that is 100 per minute, but AV node is not functioning and bundle of His is functioning. Okay, so here AV node is not functioning properly, SA node is functioning, and here AV node, this bundle of His is also functioning. But that's why if you look at atrial rate and ventricular rate. In you and me, like after P, QA will come RS and ECG will be normal over here. Why? Because like all our firing system is very well, SA node, AV node, everything is functioning properly. But in this condition, there is no relationship between over here. So that's why P and R relationship is not at all there over here. There is no relationship between P and R interval. So that's why no, like if you look over the ECG of a year, P wave is coming. I will write it over for you. And I will show like in the upcoming slides. P wave is coming. QRS is also coming. P wave, Q wave, R wave and S wave. And next P wave is also coming. And next there is no relationship between P and R. So like RR is variable over here. Like here it is also same. Like P waves are more than R waves. So this is the way how you can differentiate between complete heart block. So next it will come QRS. Like whenever they want P and whenever they want QRS, they will be coming. Like there is not like synchronous. Whenever they want, they will be coming and going like this. So like here P waves are more in this condition. Okay. And next is one more condition is whenever the bundle of his will won't fire, then who will come into the action? Purkinje fiber. So that's why when bundle of his won't function, so we'll get Mobitz 2 heart block. Okay. And next let me teach you about like what you will find ECG findings in Mobitz. So I will be discussing like, so for time being I will draw the hand diagram for you. P wave is coming, QRS is coming, T wave is coming, and next P wave is coming, QRS is coming, T wave is coming, and next here there is absent QRS complex, and next I will draw it over here and you won't find like P wave, QRS, absent QRS, and next P wave, QRS and P wave, and absent QRS and P wave. So like you will be absent of an QRS complex is absent. Why? Bundle of an His is not present in this condition. So this is about complete heart block I taught you, and AV malfunction like bundle of an His also I taught. And first degree heart block is very simple. Like what actually happens in first degree heart block in like marathon runners, like what they will be happen in this condition is like PR interval will get prolonged, right? So everything, so if you take this Mobitz heart block, like QRS will be missing. But in first degree heart block, if you look at over here, this P, Q, R and S, so which is in first degree heart block, P, Q, R and S. Okay, and P, Q, R, S, right? Look at the duration. The duration of the P and R is like prolonging, no? So like PR interval is more here. So this is about first degree heart block. And next, let me discuss about Mobitz heart block. Very, very important. So when you come this like in exam hall, if you go through the options like Mobitz 1 and Mobitz 2, I will teach you how to differentiate over them. So PQR waves, PT and P wave, QRS and T, P wave, QRS and T, everything is normal. Until here everything is normal. But look at over here, QRS is absent. Whenever QRS is absent, you have to think about heart block, right? So which Mobitz, it may be Mobitz 1 or Mobitz 2. Look at, there is missed beat is present over here. Missed beat is present over here. There is no QRS complex over here. And now you want to differentiate whether it is an Mobitz 1 or Mobitz 2. In Mobitz 1, look at this PR interval. No? PR interval after and before. No? PR interval after and before. This is PR interval. So that's why I thought you PR interval from where and how. This is PR interval. No, look at like PR duration of the PR. No, here it is like PR interval is not same, which I have marked in black. So here it is small, here it is big, right? Unequal PR with missed beat is an example for Morbitz 1. Okay. So this is the how you can differentiate Morbitz 1 and Morbitz 2. And same come to Morbitz 2 over here. Look at this. Here also missed beat. But look at the duration of the PR over here. No? They are same. Look at the duration of a PR. PR interval is same. Is same. And what about this? PR interval is same and missed beat is present. So based on the missed beat, I cannot differentiate whether it's Morbitz 1 or Morbitz 2. To differentiate it whether it is a Morbitz 1 or Morbitz 2, I need to know about PR interval. If both my PR interval is same, then that is your Morbitz 2. 2 hard block. Morbitz 1 hard block, it is also known as Wenke-Bach phenomenon, and this is about Morbitz 2 hard block. Okay, so here the problem is in bundle of an haze. Okay, in Morbitz 2, there it is the current is going in the AV node itself. In this Morbitz 1, this is the how you can differentiate in an exam all about like Morbitz 1 hot block, Morbitz 2 hot block. So hot blocks, so most of the students they will get confused in an hot blocks. So I will explain in how you can in the exam all how you can differentiate complete hot block, Morbitz 1, Morbitz 2 and all, right? So if you take this first degree hot block, so first degree hot block, in first degree hot block we all know that like in first degree hot block, like it is best example is marathon runners. So I will write it for you. So don't confuse, very important, first degree, second degree and third degree. Third degree is also known as your complete hot block. In first degree hot block, SA node to AV node conduction. Here it is present over here, right? So current is not going to AV node. So that's why your PR interval is more than 200 milliseconds, right? So best example, marathon runners. Okay. And in second degree hot block, there are two types, Morbitz 1 and Morbitz 2. So what happens over here is this is SA node and here AV node. The problem is here across the AV node. Okay. No? So this is the reason why like your PR interval is not same. No? PR is increased or missed beat is also present over here. But when you come to Morbitz 2, the problem is not in AV node. It is completely good and the problem is in bundle of hills. Okay. So this is the reason, that's why PR interval is normal, because AV node is responsible for PR interval, but in this condition like AV node is completely fine, right? So that's why PR interval is normal in this. So missed bit I have taught you over here. And in third degree, if you know like SA node to AV node and bundle of an his, here this won't function itself, no. So that's why like they will be like whenever if the teacher is not there in the class, student will be going where and here. So that's why P wave will come whenever it want and R wave it will come whenever they want, right? So there is a mismatch is present between P and R over in this condition. So this is how you can differentiate, like when you come to the exam, like Morbitz 1 and Morbitz 2 are very important, like in recent exams and also how to differentiate. So very simple, missed beat, QRS is absent, missed beat, and it's you think about two conditions that is like Morbitz 1 or Morbitz 2 and go for the PR interval. If PR is same, PR is same, Morbitz 2. If PR is different, Morbitz 1. So this is about hard blocks. And next we move to one of the most important arrhythmias like tachyarrhythmias, where you can expect questions from these aspects onwards. So like when you come to this tachyarrhythmia, like if they ask most common arrhythmia in clinical practice is don't answer ventricular fibrillation or like ventricular tachycardia. It's your atrial fibrillation is the topic of discussion. This is atrial fibrillation. So I will teach you ECG, don't worry. Atrial fibrillation. Okay. So most common arrhythmia in clinical practice is don't answer like VT or VFib. That is atrial fibrillation. Okay. And if they ask most common sustained tachyarrhythmia, sustained is nothing but for long term. That is your atrial fibrillation. Okay. So now let's see like what actually happens in this condition in atrial fibrillation over here is like, suppose imagine like this is an, I will hand draw for you. So why actually this atrial fibrillation, how these fibrillatory waves are generated? No? So this is the right atrium and left atrium. Here I am having my SA node. I thought you SA node will be firing the current, no? From right atrium to left atrium to right atrium and all. But here SA node is in normal you and me, SA node only single is present. But here some multiple foci are present. Like SA node, there are lot of firing systems are present in this right atrium. So as a result, what will be happen is like no, right? Like everybody will be start firing, like firing. So that's why like your heart rate will be more in this condition. No, so like you will find this multiple ectopic foci. Multiple ectopic focus is nothing but like if you look, see in you and me, if we sleeping also like heart will be beating, but we won't feel like heaviness of an heart is beating like no. But in this patient you will be finding like palpitations is present in this patient over here. So why? Like there is too much of an firing, like lot of fires are present, like multiple ectopic focus are present in this condition, right? Everybody are like a boss in this right atrium, so that's why everybody will be start firing over here. So that's why this is responsible for excess heart rate, that is 300 to 600 per minute. Imagine like it is 5x into 6x than normal. So this is the arrhythmia. So that's why if you look at the pulse, everything will be like irregular pulse. So how you will feel like 100, 600, 500, how pulse will become irregular pulse and absent P wave. And one more thing is variable RR interval. These are all, if the examiner will mention this in an, suppose imagine an hypertensive guy and he's having this absent P wave, then irregular pulse, you have to think about this condition, that is atrial fibrillation. So when you come into this condition, like if you look at the ECG over here, see these are like fibrillatory waves. See how the waves are coming like this, no, fibrillation waves like this. And QRS is completely fine, but you are not able to differentiate the P wave. So how you will see, like look at this condition. So how P wave is not at all coming, absent P wave. Why? Like we all know why why it is absent P wave over here is like, look at this, SA node is responsible for the P wave. Here SA node itself is not functioning, like everybody or bosses like more SA nodes are functioning, like SA node itself is get confusing. SA node can fire until 100, I thought you in max, but here like lot of multiple false focus are present, they are more dominant, they are dominating the SA node. So that's why like P wave is not generated over here. So this is the reason why like in most of the books they will be telling like absent P wave. So this is the reason about absent P wave. So one of the cause is like hypertension, like the examiner will mention a geriatric age group, right? Old age people will be more prone for this condition. And next, when we come to this treatment, right? Treatment aspect. So what are all the treatment you are going to use? The mnemonic is RACE. Okay. R. So what this R stands for is like rate control. So rate, so why this rate control? It is beating very very fast, no, like very very ectopic focus, they are beating very 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 fast. So that's why I should control the rate. For rate control, which drug you are going to use? Esmolol, beta blocker. Esmolol is the drug which you are going to use over here. And next, anticoagulants. Why? Because if there is like multiple clots are present in this right atrium, it is very dangerous, no, if the same clot, it will go to the brain. So sustained, why I am telling is like the patient is still alive. If you won't treat this condition, the patient can go to the stroke. If the same clot by through the circulation, if it goes to the brain, that leads to the stroke in this patient. So that is an anticoagulation. So what are all the anticoagulant drugs? That is apixaban and dabigatran are the drugs which, and warfarin also can be used over here. And this C, what this C stands for? Chemical cardioversion. Like this is nothing but your rhythm control. No, for rhythm control, what drug I am going to give? IV amiodarone. Okay, and E stands for electric cardioversion. So these are the steps you are going to follow in atrial fibrillation. Electric cardioversion, which you are, what you are going to do? DC shock. How much? 200 joules. Okay. So like in cardioversion, what you are going to do? You are going to put this synchronized DC shock. So what do we do in cardioversion is you are going to provide synchronized DC shock. So what do you mean by synchronized DC shock is like when you attach this ECG monitors and the defibrillator paddles and all, like, right, to identify the rhythm and all, like the computer itself, it identifies the rhythm and it delivers the shock on particularly R wave. If anything which delivers, if the rhythm is identified and if it delivers the shock on this R wave, that is known as synchronized DC shock. In unsynchronized DC shock, we will be using in like ventricular fibrillation and PVT, pulseless ventricular tachycardia, right? There it is the only condition in the cardiology where you are going to use this unsynchronized DC shock. Unsynchronized DC shock is like the machine cannot identify the R wave. Whenever the machine cannot identify the R wave, so that leads to unsynchronized DC shock. And this is about atrial fibrillation. And next we move to atrial flutter. So atrial flutter is like nothing but I taught in earlier in atrial fibrillation, same diagram, simple diagram, right atrium and left atrium. But here what will happen, there are lot of multiple ectopic foci is present, but here only single foci is present and it is roaming around here itself. Here itself, okay. So there lot of bosses are there, but here single boss, but it is roaming in the same circuit. No, it is not going to the left atrium and all. So that's why there is an re-entrant circuit, macro re-entrant circuit. Okay. So that's why if you look at the heart rate in atrial flutter over here is like heart rate is like 250 to 300 beats per minute. Okay. Like we know in atrial fibrillation heart rate is more 300 to 600 beats per minute. So here what is the major cause for this atrial flutter is like, look at the ECG over here, P wave is present, but if you look at these waves, no, it is like this. So this is known as sawtooth pattern. Okay. So this is about sawtooth pattern. This wala. This is sawtooth pattern. Very important. So the major reason for this is like COPD patient. No, COPD patients, they will be complaining of palpitations and recurrent syncopal attacks, right? So if the examiner says COPD patient, think about flutter. And if he mentions sawtooth pattern, then it's very easy for you, that is flutter. Okay, so here also same, beating fast, RACE, same, rate control, anticoagulation, and chemical cardioversion. E stands for electric cardioversion. Here remember, in the cardiology I am telling, if this is the condition where you are going to give this low intensity DC shock. Okay, low intensity DC shock, how much? 25 to 50 joules. Why I am giving low intensity DC shock over here is, remember why I am giving low intensity DC shock? Yes, but here if you look at the heart rate in atrial fibrillation, it's 600, here it is 300, so that's why I should give low intensity. And if they ask non-synchronized DC shock, where you are going to give ventricular fibrillation and pulseless ventricular tachycardia. Keep in this mind, non-synchronized is nothing but it doesn't deliver the shock on the R wave. Why? The machine cannot identify the R wave in these conditions. Okay, so this is about atrial fibrillation. So what is MAT? MAT is very easy. MAT is nothing but multifocal atrial tachycardia. So it's very simple. Like if in exam, if you look at the morphology of, the P wave, no, here it is small and here it is big and here it is completely big. Same here also, small, small, big, right? So look at the morphologies, arrows, look at the arrows. They're beautifully showing like greater than 3 morphology of P waves, right? P wave morphology or height, it is greater than, like it is different more than 3, that is known as MAT. MAT is nothing but multifocal atrial tachycardia. So what we are going to use is verampimal, right? Is a bit of this calcium channel blocker we are going to use over here. Verampamil is the drug which are going to use over here. And next, very important, paroxysmal supraventricular tachycardia over here, very important. Like here the examiner, this condition is common in young patients such as young female. Suppose an young female has came to your OPD and she's like she has a recurrent syncopal attack after drinking tea and coffee, and suppose she want to go for an office in the morning and she skipped her meals, and like everybody will be thinking like if anybody get this syncopal attack in the morning or they'll be thinking like anxiety is present in this female, so they will consult this psychiatrist and they'll be taking this anxiety tablet, that and all. Like after few days this condition will not get treated in this patient. So like if you look like what happened over here is like very important. So look at what there is, like a recurrent syncopal attack in an young female. So why it is happening is like paroxysmal is, what do you mean by this paroxysmal? Like start and drop, right? It will come, it will go, it will come, it will go. The syncopal attacks will be coming and going in this patient. So why it is happening is there is re-entry of an current in the circuit, right? It is like circus movement. So like if you look into what it is happen over here is, so I taught you like the previously the current is roaming in all the above conditions in the right atrium itself, no? So in all the above condition, right atrium, left atrium, but here the current is over the here, where in AV nodal, this is an AV node, no? So the problem is in around this AV node, so that's why the current is going on over here. But here sometime it will fire and it will become less. So that's why whenever if you look at the ECG of this patient, P wave, Q, R, S and T is also coming. P wave and Q wave will become, whenever this fire, it will fire, no, this abnormal current will come in this condition. So then what will happen? Your QRS complex will become narrow in this patient. Okay, and next T wave will come. So whenever the syncopal attack will get terminated, the patient ECGs will be absolutely normal in this condition. So this is the reason. And look at this, like what happened over here is like if the female will wash the face with this cold water, this condition will become improvement. They have been shown like improvement. So that's why like if you do this carotid sinus massage, there will be an improvement in this condition. So that's why like if I apply this ice packs and all, like there will be an improvement in this condition. Why? There will be an activation of this vagus and all. So this is about treatment aspect over here. Vagus stimulation will leads to the very good like termination of this abnormal current. Okay, so this is about paroxysmal supraventricular tachycardia. Okay, so like young female, she's coming with recurrent syncopal attack. Think about this, which, and look at the QRS complex over here, like it is very very narrow. No, like how much I thought you it is like 80 to, it will fit in like 80 to like 100 in the sense like 2 to 2.5 and all, but in this condition it is like completely narrow over here. Look at the QRS complex, it will be narrow QRS in this condition. Okay, and this is about this. And treatment, very important. So remember, examiner, this is the only condition which will be seen in the young patients, like carotid sinus massage, carotid massage, and you can see like vagus that leads to vagus stimulation, and ice pack. Okay, and like drug of choice, if they ask drug of choice for PSVT is adenosine. Okay, this is about how you can solve the question. And these are like you can go with this, like if the PP is unstable, then you can go with this cardio version also. So these are all about treatment aspect over here. And next we move on to this one of the most important. Oh, and one more thing I would like to mention in this PSVT is like Holter monitoring. So one of the students, they asked like Holter monitoring where it will be fine, and let's see in paroxysmal supra. What this Holter monitoring will do is like I told you, no, whenever there is like abnormal current, like so like suppose imagine in the home the female has this syncopal attack. After some time, like she will become normal in this condition, and when she become normal, she came to your OPD and you did an ECG. By doing that ECG, what it will be happen in this condition is like ECG is normal, and if you show this like to your family members, and they are like that, they will be thinking like you are cheating them, and like so that's why you will put this Holter monitoring. What this Holter will monitoring, what this Holter will do is like it will be keep on monitoring the heart, right? So whenever this, suppose imagine at evening 4 o'clock, the female heart rate is completely normal. At 4:20, she has this syncopal attack. At this time, what will be happen? My QRS complex will become narrow. No? This is the reason why this Holter, it will be monitoring 24 into 7. Right? So this is like I will be inserting this Holter monitoring, and it will be reading. Whenever next follow-up she come to my OPD, I will take this chip over here and cord over here, and I will record, but it will show at what time this it has been happened in this condition. Okay, so like this is about paroxysmal supraventricular tachycardia. If the heart is beating too fast, I should put brake on that. So that's why I will put this ICD, implanted cardioverter defibrillator, but not in this condition. Okay, and in bradyarrhythmias, I can put this like a pacemaker, artificial pacemaker also. No, like it will be increase the heartbeat and no pacemaker. If SN node is not functioning, then I should put this artificial pacemaker in bradyarrhythmia. In tachy, heart is beating too fast, so that's why I should put brake on it. So that's why I can put ICD, implanted cardioverter defibrillator. And this is about paroxysmal supraventricular tachycardia, and drug of choice is adenosine. And next, if you come to this like ventricular tachycardia, so what actually happens in this ventricular tachycardia is, look at the QRS complex. It is very wide, so that's why it is broad QRS, right? So like how, like look at this, how QRS is like anything which is going up, I already told that is R wave, and anything which is coming down is that thing is your S wave. Okay, so what happens over here is same. ectopic focus is present in ventricles. Okay, so that's why atrial rate is normal, and for ectopic focus and ventricular rate is like totally different. So that is like single focus, like ventricular rate will be more over here, that is 200 per minute. So that's why it is like heart is beating very very fast. So that's why like BP will crush of the patient. So that's why BP you cannot record itself in this condition. So here same thing, like if the ectopic foci it is present in the atria, that is its atrial flutter. If the ectopic focus that is present in your ventricle, that is your ventricular tachycardia. Here it is like broad QRS is found in this condition. So heart is beating very 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 fast. So that's why BP of this patient will become very very low or crushing BP. No? BP will get crushed in this patient. So that is called as pulseless. So that is about pulseless. So if they will be telling no pulseless ventricular tachycardia. So nothing but heart is beating very very fast. So that's why BP is crushing. So that's why you cannot able to feel the pulse. Okay. So drug of choice is nothing but for this ventricular monomorphic ventricular tachycardia is like IV amiodarone. Like if the patient is stable, okay, if it is pulseless ventricular tachycardia, pulseless VT, heart like BP is not recordable, then you should give this defibrillator shock to this patient. Okay, this is the major difference over here. And next, polymorphic ventricular tachycardia is nothing but, look at the morphology, right? Here, look at this, like monomorphic is nothing but same, right? So look at all the ECGs in this condition are same over here, right? But here it is like different. So this is about polymorphic ventricular tachycardia. But when you come to over here, where it is find is whenever potassium value is less, calcium value is less, and magnesium value is less, you will find this polymorphic ventricular tachycardia. It is also known as torsades de point. Torsades de points. Okay. And like what are all the drug you are going to give over here is magnesium sulfate, yes, which is used in like in your option gynae for eclampsia and all. Same drug I am going to use over here, magnesium sulfate. And these are all about your ECGs, like, and here it's like this is very simple ECG. This you will be seeing in like ventricular fibrillation, like you should hand draw like this now. Ventricular fibrillation. So here you should always give this shock to this patient. DC shock is the treatment over here. So these are all about fibrillatory, and you know monomorphic and polymorphic. Mono is something which is same, QRS complex is same, right? So broad QRS, think about two, monomorphic and polymorphic. Monomorphic is something which is like everything is same, like morphology is same. If morphology is different, then it is polymorphic. Treatment is also different. There I can give, if the patient is stable, there here I can give this amiodarone. If it is not stable, then I can go for defibrillator. And these are all about ECGs and how the waves it will cause, normal, everything and all. So let me draw all the ECG, hand draw ECG at a single point where that will be very helpful for you. So you can also hand draw with me so that you won't get forgot over here. So let me teach you about atrial pathology first. Atrial fibrillation. So what will be happen? Fibrillatory waves, absent P waves, QRS is coming, absent P waves, QRS is coming here. Irregular RR rhythm. This is irregular RR interval. So best, what is the treatment? Esmolol. Okay, rate and rhythm control I should do. And next is atrial flutter. That atrial flutter is nothing but your sawtooth pattern. So like this. So this is about same treatment here also, it is same esmolol. And next PSVT, don't confuse with this with like pulseless PVT, pulseless ventricular tachycardia, that is totally different. No, here I will find narrow QRS, there broad QRS. P wave is coming and QRS is narrow. P wave is coming and QRS is narrow. P wave is coming and my QRS is narrow. P wave is coming, sorry, P wave, narrow QRS. P wave and with narrow QRS. No? So this is the over here PSVT. Drug of choice for PSVT is adenosine. Okay. And ventricular tachycardia, monomorphic ventricular tachycardia, like this. No? Same. And you may find these notchings also. Sorry. No? This is like monomorphic, right? Which is same. So what is the drug of choice for here? It is also amiodarone. Or you can give this is also like lignocaine. Okay. And next, polymorphic ventricular tachycardia or torsades de point. Like here the waves will be not similar. One will be like this and like this and same like this, and this is the one which you are going. So best drug, magnesium sulfate. And last VFib, like this. No? So here DC shock. And if my ECG is like this straight one, asystole, movies and all they will be showing no straight one, that is your asystole. Remember one condition I will teach you now, like asystole is contraindicated, this DC shock is contraindicated in asystole. Okay, this is unsynchronized, unsynchronized. So these are all about ECG session. So ECGs are very, and MAT, multifocal atrial tachycardia, P wave, QRS, T wave and P wave, QRS, P wave and QRS and T wave and P wave, QRS and T wave. Morphology P, P and P, right? Greater than 3 P waves. Morphology of the P waves are different. 3 different P waves. So what you are going, Verampimal, right? Verampimal is the drug which you are going to use over here. And this is about MAT, multifocal atrial tachycardia. And Morbitz 1 and Morbitz 2 we know. Morbitz 1 and Morbitz 2. Morbitz 1 is very simple, unequal PR. If PR is normal, so that is like Morbitz 2 heart block. Here missed beat is present both on that. So that's why we cannot rely on this, no? Missed beat. Okay. And this is about how we can, all the types of an ECG which I have described in this above session are very, very important for not only for your exams, like all these images are very, very important. Please go through the images carefully, and thank you for hearing guys, and keep studying.